Hi everyone, my name is Jeff Duchin. I'm the Health Officer for Public Health, Seattle and King County, and one of the co-chairs of the King County and Seattle Heroin and Opiate Addiction Task Force. I'm here with my colleague.
Hi, I'm Brad Finegood. I co-chair the Heroin and Opiate Prescription Task Force with Dr. Duchin. I had the honor to. I am an Assistant Division Director for King County Behavioral Health and Recovery Division. Our division is responsible for all of the mental health and substance use disorder treatment for the Medicaid and low-income populations across King County.
And we're here today to share information with you about the task force recommendations and take your questions. And Brad's going to kick it off.
Yeah, thank you everybody for joining us today. We wanted to take this opportunity to have a conversation with the community and talk a little bit about why we chose in our task force to recommend what we call community health engagement locations, or CHEL sites, which are places where people can engage in health services who are currently using intravenous and other drugs, and use in a safe space so they are not vulnerable. So this task force started in 2016. It started as a response to a 2015. In 2015, a drug trends report was released that talked about the 2014 drug trends data, because there's a lag in data reporting. And what that 2015 drug trends report said is that King County, like so many other places around the state and around the country, were experiencing an all-time high in drug overdose deaths. Of course, that sent shockwaves and alarm through our whole community and our whole system, although drug deaths have been escalating. And trying to figure out, how do we get in front of this as a community? So in response, the Seattle Mayor Ed Murray and the King County Executive Dow Constantine got together and said, we need to bring together the experts in a very short time frame to figure out how can we get ahead of this problem. Because one of the unique things about opiate use disorder is that we have tools. And so it's about, how do we take the tools that we have and use the tools. So there were over 40 people who came to the table in this task force. We wanted this not to be a task force that was about process, but we wanted this to be a task force that was about implementation and doing something. And so from the beginning, it was clear and evident that all the different people that were at the table, from people with lived experience as far as having family members in recovery, people who identified as active drug users, law enforcement, medical professionals, treatment professionals, and other concerned community members that worked with youth and adults and elderly of all sorts, came together and said, we're all impacted by this in different ways, and we need to be able to get ahead of this. And together, collectively, we can do something about this. So we sat down and we said, what can we do? And over 6 months, we broke into 3 work groups. We broke into a prevention work group, we broke into a treatment work group, and we broke into a work group around user health services. We didn't want to come up with 55, 100 different strategies that we were going to really have trouble implementing. So what we decided to do was stay as high level as we can and figure out what was going to make the biggest global impact for the people who were impacted by opiate use disorder, heroin use, prescription drug use, all of these types of things. And so we broke into a prevention work group, treatment work group, and user health work group. The prevention work group basically came up with 3 recommendations, because it's super important for us to acknowledge that we need to be able to get ahead of this curve. One of the things we identified early on is that 80% of people who start using heroin started with prescription drugs, right? So if we can get ahead of this and start to work towards changing prescribing habits and the way people use prescription drugs, then we can start to get ahead of this curve. So we came up with 3 recommendations. We came up with better screening for youth, safe disposal of unused medication, and locking up medication that was in medicine cabinets. And then around destigmatization and public education around opiate use disorder. Then we moved on to our treatment work group, and our treatment work group also had 3 recommendations. And they were all basically expanding treatment. We know that medication-assisted treatment works. Medication-assisted treatment is our biggest tool. It is really the gold standard for treating opiate use disorder. And so the more that we can expand treatment with medication-assisted treatment and abstinence-based treatment that people want, but give people treatment that they want and that they need close to where they live, then the more we're going to be successful. And then the last work group, which Jeff is going to talk a little bit more, had two recommendations. One about naloxone, which is this amazing, miraculous drug that reverses somebody who is in active drug overdose and brings them back to. And then about setting up these sites that we've called community health engagement locations, or CHEL sites.
Thanks, Brad. When we made our task force recommendations, we started from the premise, and this is very important for all of us to understand, that addiction or substance use disorder is a disease. It's not a moral failure or a lifestyle choice. That is an issue of willpower. So, for example, when someone suffers from addiction, whether it be to opiate use, to opiates or heroin, to alcohol, to tobacco, there are real physical changes in the brain. There are changes in neurotransmitters, there are changes in the receptors that are on the neurons in the brain, there are changes in the size of different regions of the brain. All of these have really conclusively established that addiction is a physical disorder of brain chemistry. So we need to treat it like a chronic disease, similar to how we treat other chronic diseases like diabetes and hypertension. Long-term treatment and patients who have substance use disorder, suffer from addiction, are susceptible to relapse, so they need to be treated for long periods. We also know that not everyone who suffers from addiction is ready for treatment on any given day. And we have done studies locally that have shown us in 2015 about a third of persons who are not currently in treatment, who have opiate or heroin substance use disorder, are not ready to enter treatment. And that's no different than what you might experience among people you may be familiar with who are subject to alcoholism or tobacco use, many of whom would love to quit. They know it's damaging to their health, but they can't do it on any given day. They're just not ready to enter treatment. So what is a CHEL site? These are locations, they're public health services that provide a safe space for people who are already using drugs in public spaces, in alleyways, in restrooms, in local restaurants or businesses, in an unsafe environment. Allow them to come indoors under the supervision of a healthcare worker, use their drugs, and have an overdose reversed if they should suffer from an overdose, and have life-saving treatment administered. That could be through naloxone, rescue breathing, or oxygen, where they can access medical services that they may need, including access to health care, social services, behavioral health services, and very importantly, a key is access to treatment, medication-assisted treatment for opiate use disorder in this case, or addiction, and where we can decrease the amount of public injection that's going on and the associated public safety hazard of discarded injection equipment. So it's key to understand that these sites are really targeted to be used in areas where there's a lot of public injection already happening, that they do not provide drugs or allow drug dealing on the premises, they do not administer, staff will not administer drugs, and that these are a proposal that has been tied to a very strong and requirement for evaluation. So the task force will be evaluating the impact of these facilities both on the people who use them, expecting to see benefit, and on the communities around them. And we don't expect to see any adverse effect on those communities, and we'll talk more about that in a few minutes.
So one of the questions that we get often asked to us is about why not focus more on treatment. And I think that's a really good question, and I think to understand that question is to help understand the whole treatment system. So currently, we spend in King County over a biennium, so over a 2-year time period, approximately $200 million on treatment resources to go towards people with substance use disorder or that are available to people with substance use disorder. Some of them have what we call co-occurring issues or comorbid issues where they might also have some other types of health conditions, or they might also have mental health conditions, but it's our goal to treat the whole person. So we pour a tremendous amount of resources every single year into people with substance use disorder. If we didn't do that, our situation in our county and in our region would be tremendously worse. We have a tremendous amount of people who are currently receiving medication-assisted treatment, and our goal is to develop a system where we get to treatment on demand. Because part of what a CHEL site is one of the things, not the only thing, but one of the things is it's an avenue for people to access services. So Jeff did a great job of describing the array of services that were going to be available at a CHEL site. We want people, when they're ready to make a change, to have access to services. We put a tremendous amount of resource, time, and energy in this county into developing a system where we can provide treatment on demand. We're expanding local bed capacity with our detox facilities. We're providing non-traditional services where our new detox facility that's coming on board will also be able to provide medication-assisted treatment for people with opiate use disorder. And we're starting new and innovative low-barrier programs like at the Downtown Public Health Needle Exchange, where when people walk in, we're working to a point where they can get started on medication within 15-20 minutes. That's the system that we're developing. That's the system that we're working towards. And so, but as Jeff articulated, there's a small percentage of people who may not want treatment that day, or who may not avail themselves to treatment that day, or who aren't ready for treatment that day. It's still our responsibility to keep those people alive and develop a relationship with those people so when they are ready to access treatment, that we'll be there for them. We've heard time and time and time again from people with lived experience that what's made the most significant change for them is the relationship that they've been able to build with helping professionals, so that when they were ready to make a change, that they would have a safe place to go to for ask for help. If we continue to alienate people who are most vulnerable, we put them in higher risk of acquiring disease, of overdose, and of being victims of other people. And so what we need to do is, all that we're saying is bring those people indoors. We're gonna take a warm approach to engagement, and then hopefully when you're ready for treatment and accessing treatment, we are here to provide treatment.
That's right, and I would emphasize that these sites are really targeted towards hard-to-reach, marginalized persons, people who don't feel they have the opportunity to engage with our healthcare system in any other way. Many of these people are homeless. Many of them have mental illness or other behavioral health issues. So it's really a very specific intervention targeted at our most vulnerable and marginalized persons with substance use disorder.
So I know you plan to talk about it, but we have a lot of questions coming in about how these sites could compare to the Vancouver model. People are familiar with that. Can you speak to it a little bit?
Do you want to talk about that, or let me talk
Yeah,
about
sure. So, through our research, and Jeff will talk about the research on CHELs, because this is an extremely well researched intervention. This is not a willy-nilly intervention that just we had this harebrained idea here in Seattle, King County. There's, from what our research tells us, there's over 100 of these facilities worldwide. Our closest one, actually it's not even our closest one anymore, but historically our closest one has been in Vancouver, BC, in the East Hastings neighborhood. The Insight was set up to deal with an already existing difficult situation in a neighborhood of East Hastings that we don't really have comparison to here in Seattle, King County. We don't really have neighborhoods that compare to what the East Hastings neighborhood, what that looks like. And that's nothing against anybody in Vancouver. What we've been able to learn from them has been amazing. But as a result of this being a well-researched, well-studied intervention, these are popping up all over the place. So in Canada right now, and they're all over Europe, Australia, and Canada. So in Canada right now, we just learned that they have two different types of facilities. One is a supervised consumption space, where they're getting federal approval for it, and the other, which they provided local approval for, is these overdose prevention sites where people can use safely on site. And so, they're a response locally to the overdose issues on multiple different scales. So on Victoria Island they have these. On Vancouver Island in Victoria they have these. So they're all over in response to the epidemic that's happening.
Yeah, and I would say that the neighborhood where the Insight Vancouver supervised consumption facility is located is very different than our city. It was always different even before that facility was located there, and in fact that is one of the reasons why it was located there. But there's no reason to think that that facility caused that neighborhood to have the very high levels of homelessness and public injecting that are going on there. It was placed there because of those problems. If you look at the many other facilities around the world, they don't look like downtown Vancouver site either. They look like their own communities. And the research that has been done has not shown any adverse impact with respect to public safety on the communities in which these facilities are located. So I would raise that again. Many of our healthcare colleagues on the task force visited many sites in Europe, and they each are different. They each reflect the community in which they've been placed, but none of them have been linked to public safety problems in the areas where they've been located.
Can I add a couple more things?
Sure.
So, we've seen pictures of supervised consumption of parks in Zurich that were overcome with people publicly injecting drugs. So huge communities of people in these parks. And then they set up a supervised consumption space just blocks away. And all of a sudden, not all of a sudden and not overnight, but over time, the park cleaned up. There was no more public injection. And what ended up happening was they were able to revitalize that green space. And now it's available for families and community members. The other thing I'll say about the Vancouver Insight facility is one of the questions that we've been asked often is about treatment admission and a low amount of treatment admission. I think it goes to say that they have hundreds and hundreds of unduplicated injections a day there, and they have a 16-bed detox facility upstairs. So the amount and capacity to serve is minuscule versus the need for service. And I would venture to say that different designs would say that maybe detox isn't the best idea that we have. So can we get somebody started on medication that's going to help them from the get-go rather than providing a detox facility with small capacity on site?
Let me backtrack for a minute and just talk about what the goals are of these sites. There are three main goals. One is to prevent drug-related harms, including overdose and transmission of bloodborne viruses such as HIV, hepatitis C, hepatitis B, and other bacterial infections. One is to provide linkage to treatment. When you're ready for treatment, we want to be there with a trusting relationship that can allow that person to enter treatment and be successful in treatment. And finally, to decrease the public safety problem from injecting in public locations and discarded injection equipment in restrooms, in public facilities, in parks, and so on. And we do know from the research that has been done on these over 90 sites over 30 years that these sites have been successful in decreasing overdose deaths, in reducing public use in these locations such as parks and restaurants and alleyways, and linking users to treatment and services. They have not been shown to cause an increase in the frequency of drug use, in initiation of drug use, or in public safety problems in the communities in which they've been located, and we are fully committed, as I said, to evaluating our sites for both positive and negative impact and making any and all appropriate measures, steps to address any problems or to enhance any benefits that we might observe.
I think it's also worth noting that we're not the only jurisdiction and area community that's looking at these sites in the United States. There's activity in San Francisco. In fact, the California House is the first major state house that passed a bill in support of supervised consumption. They're looking at these possibly in New York, where the city of New York has a task force that was asked to look at these, in Albany, in Philadelphia, in Baltimore. There's two recent studies that came out, one out of San Francisco and one out of Baltimore, that showed significant health savings in a cost benefit analysis. In Baltimore, there was a recently published about 2 weeks ago that they could save up to about $6 million in health savings costs if they stood up supervised consumption spaces.
That's right. And what Brad says is true. These are not unique to our area. Again, it's not a new concept. As a matter of fact, the American Public Health Association endorsed this strategy years ago. The Infectious Disease Society of America endorses this strategy. The HIV Medical Association endorses this strategy. And the Massachusetts Medical Society, which is the most prestigious state medical society in our country, which publishes the New England Journal of Medicine, also has endorsed this strategy on a pilot basis for evaluation.
Can you speak to the costs associated with this program and how we might pay for it?
Sure.
Yeah, I think the costs are going to vary. Like I said before, we spend about $200 million over that across a biennium on treatment services. The costs comparatively are going to be extremely small. Different design models and where this is located is going to be very much dependent. How many booths, what's the, how many healthcare workers do we need on site, all of that type of stuff. But the estimates range between $500,000 to $1 or $2 million a year to be able to start and staff these facilities.
And again, we're hoping that, as has been seen in other communities, these would be cost-effective interventions that would be potentially cost savings. But certainly, we don't believe that someone should be pushed out onto the street after they're given clean injection equipment, as we provide around the country in our needle exchanges, and told to go inject in an alleyway or in a restroom of a coffee shop unattended, where you could die alone, when we could save a life, intervene, and link someone to treatment simply by letting them do that indoors under medical supervision.
Can you speak to this directly one more time? People are concerned that these sites will encourage drug use.
Mm-hmm. Well, the research doesn't support that. As I said, there's been a large body of research on the many sites in Europe, on the site in Vancouver, BC, none of which have shown that the sites result in an increase in drug use or an increase in the initiation of drug use. We had these same concerns around needle exchange. For many years, people thought if we set up needle exchange and give people clean injection equipment, we're just going to invite people to start using drugs and use them more frequently. However, that's been shown not to be the case, and in those years during which people opposed needle exchanges, hundreds of thousands of cases of HIV and other bloodborne virus infections that were preventable occurred. There were thousands of preventable deaths that occurred, and now we know that needle exchange is a safe and effective intervention to save lives and prevent disease. I think we're going to see the same thing with these supervised consumption facilities in the United States. We're just a little bit behind the curve. This has been very well accepted in many other countries for many years, but it's a new idea to many of us, and we understand why it takes a while for people to become comfortable with the evidence.
And I think also it goes to making sure that when we do this well, and that it's cited appropriately in a place where it's going to make an impact. A lot of the work that we're doing now is the where do these need to go. We have no interest in citing these in a community that doesn't have these problems, right? The idea behind a supervised consumption space is where are the problems already happening? Where are people overdosing outside? Where are needles being discarded outside? Where are people dying from heroin use? We have a lot of that information, and so by looking at that information, the premise is that people are already using publicly. We know that. I came across somebody overdosing last week on my walk to the bus. A colleague of mine walked into a Starbucks a couple weeks ago, and somebody was overdosing in the bathroom. These things are happening already, and this is just an intervention that says you do not need to use alone, you do not need to be stigmatized or have prejudice or discrimination because of your illness. Come indoors, talk to a healthcare worker, and we can help.
Giving people a safe place to inject who are already injecting in unsafe ways doesn't in any way invite more drug use.
Okay, 2 more quick questions.
Sure.
Do we have a timeline for opening, and how will we know this is working?
Should I take that?
Sure.
Well, our timeline is we would have liked to have done this yesterday. We're looking very hard at potential locations, and when we find a potential location in an area where there's a lot of public use going on and a lot of vulnerable patients or people using drugs in public, will engage with that community to discuss whether or not we can locate in that area. But at this time, we don't have a site identified. What was the second question?
How will we know it's working?
Oh, well, we have a very robust evaluation plan. We're partnering with the University of Washington on evaluation. We also are committed to engage other evaluators once we have this site identified, and we are only committed to evaluate this proposal for 3 years. At that time, we can reassess whether or not it's working in our community.
And I think, to Jeff's point, we would really have liked to have done this yesterday or months ago. every day, somebody dies in King County approximately every 36 hours due to heroin and opiate overdose. So by the numbers, if we don't have a facility set up where people can come and be safe, but in a day and a half from now, then somebody's life is in jeopardy. I can say for myself, my brother died of a drug overdose, and so for me, this is extremely, it hits hard, it's extremely personal. We're working actively to try to figure this out and to try to implement, but in the interim, we're working extremely hard on prevention measures and expanding access to treatment. We've been able to turn out over 1,500 Naloxone kits since our task force started. We have approximately 60 overdose reversals that have been attributed to Naloxone kits that we've been able to get out. We've also been able to start low barrier programs where people can access treatment as close to on demand as we've been able to come. We've started other types of programs. We've worked recently with the legislature to have a bill passed that would reduce barriers on getting medication-assisted treatment clinics stood up. And so in the interim, it's about these CHEL sites, but it's really about the whole task force recommendations. CHEL sites alone will not do the answer. It's about a comprehensive set of recommendations that will start to move the needle and reverse the overdose trends.
That's a very important point. And I also want to say one other thing that we're thinking about is the increase in fentanyl and very highly potent drugs that are being seen around the country. We've noticed a small increase here locally. These drugs are 50 to 100 times more potent than heroin or morphine and can lead to explosive increases in overdose with staggering numbers of deaths. So we would love to have every tool at our disposal available in our community to help save lives now, and especially if this problem gets worse.
And I know we got to go, but one last statistic that I'll leave everybody with that rocked my world, that was really important to me. Out of the 90 or 100 or more facilities worldwide that have been stood up that provide supervised consumption spaces like we're proposing and attempting to do, there have been zero overdose deaths in any of these facilities worldwide. That to me is amazing. When we have a tool that we can use that will help keep people alive to the point where they can get help, where we know that they won't die because we have healthcare workers on staff and we have tools to reverse overdose, there's been zero overdose deaths in these facilities worldwide.
And on behalf of Brad and myself, I'd like to thank you for your interest in this problem, for learning about it, and we look forward to speaking with you again.